with regard to pre-transplant strategies, we might see whether we can optimize it in the way that more people are getting MRD negative prior to transplant. That could be one option, but the problem is we don't have the tools for it so far, different from acute lymphoblastic leukemia, where we have, for example, blinatumomab or inotuzumab. That is not the case in AML. So I think that we will move forward to start very early with preemptive therapies driven by MRD. And yes, and then we probably will try some of the drugs we have already. For example, also as a maintenance therapy, we have the MORPHO trial. Results are expected with regard to Gilteritinib. And there might be also others like oral AZA that might move into the field for a maintenance therapy. And in those who already suffer from relapse, as I already mentioned, I would say that we will probably have a more individualized treatment for those patients. And finally, but I'm not sure how far that will go, we might also have cellular therapies also in AML patients, but the problem so far is that the target is also present on non-malignant cells, and this is the limitation of this approach in the myeloid diseases so far.